I don't know if I've met everyone. I've met some people. I'm Zoe Palmer. I'm one of the consultants in palliative medicine. So this talk will be interactive, and it's talking about a case to kind of try and get you to think about some of the principles of palliative medicine and how we care for patients who are under our care. It will be interactive. You can log in on Slido if you've not used it before. Basically, you can put any name in. You don't have to put your own name. You can make something up. It's a quiz and different forms that you can do word clouds and things. If you answer the quiz questions, your points will be based on how quickly you answer them and whether you get it right or not. So I'm hoping, I don't know if this works. So just in terms of emotional safety, end-of-life care, palliative care can be quite difficult to talk about. They're quite challenging cases sometimes. Sometimes there's a little bit too much close for comfort, depending on what we're going through emotionally and personally ourselves. If that is an issue, then don't be afraid to leave the room if you find it too overwhelming or difficult. But if you do that, please let Nikki or me know that you're okay. And slides should be available later if it's difficult or the wrong time for you. I think they also are recording this, but I can't quite work out where it is available online, but I think it will be available for people who aren't here. So next slide. This slide talk's going to cover who dies in hospital, why it's relevant to you. Pretty much every specialty in this hospital will look after somebody or someone who is dying at some point. As palliative care consultants in a team, I work on an advisory basis, so I don't have a core set of patients who are kind of solely held under my care, but I will go to every area of the hospital and provide advice, apart from tend not to get involved in paediatrics. That's more specialist, that's a different specialty, but occasionally there's a children's hospice affiliated to the local hospice in Goring, so we have had some sort of previous experience of particularly transitional care, which is teenagers. So the ambitions framework is basically an NHS framework outlining kind of goals for palliative care and end-of-life care in the NHS. There's 6 principles. It covers from 2021 to 2026. This particular framework is about each person being seen as an individual, everyone having equality and access to care, so equitable access to care, ensuring symptoms are managed to maximise comfort and well-being, to make sure that we work collaboratively and to make sure that we are prepared to care, but in order to be prepared to care, you have to have the knowledge and skills and training to do that. And research has shown that caring for patients at the end of life is one of the most challenging and traumatic things that often is experienced by nursing staff and healthcare professionals in their first year after qualification. So we are trying quite hard as a palliative care team to make sure that we educate and teach all of the staff about how to do this, because it is something that happens every day. So if you joined Slido, I don't know if you already joined the quiz. Is it working for you? You're all on, I think it will then take, I don't know if it automatically takes the next question, or do I take you to? I'll see. Is that everyone pretty much? Okay. Let's see if it works. So how many patients admitted to hospital, this is adult patients, through the acute take are in their last year of life? And this is data based on a Royal College of Physicians report done called Talking About Dying in 2018. And it summarised a number of statistics and information about dying. So, correct answer is 1 in 3. Okay, so this is patients who are roughly in their last year of life. This isn't during COVID, and I suspect it was much higher sometimes than this. And it's adult patients. So they, potentially. See the board? So the next question is, what number of patients being admitted through the acute take will actually die on average? This is again adult patients based on the same data. Yeah. So, yeah, it's actually 1 in 10. So we're not quite as bad as you think, but roughly, I think if you take a ward of, I think we're really terrible. If you take a ward of 30 patients, roughly a third may be in their last year of life, and roughly 3 of those patients would potentially die during that admission. I think our local population is very elderly. They have often comorbidity, so we do see quite a few people who actually have longer stays in hospital and don't survive and aren't discharged because they end up dying in hospital, very sadly. So a study done in 2012 showed what percentage of hospital complaints relate to end-of-life care. Sorry, we were a bit late and stuff because of all the IT stuff. So, but the answer, the answer is 50% potentially. So locally, I sit and I help. I review responses and of complaints that come in relating to end-of-life care. It consistently is not necessarily 50% here, but end-of-life care, dying and how someone is cared for when they're dying, and circumstances around that consistently comes up in the top sort of 5 themes that we look at, and so it's a really important issue.
Can I ask, is it normally specific things like communication?
I suspect, yeah, predominantly communication. There's a lot about communication and out of hours, and yeah. I think, but even when there's been really good communication, there's still things that happen if patients' relatives come in for a procedure and die unexpectedly and deteriorate much more quickly than anticipated, or actually if they're told their relative's dying and it takes a lot longer, and then they start questioning things. There's lots of different themes, so it's not just purely about, but some of that is communication based actually. So this is a letter of feedback that we had from a relative a few years ago. Basically, he was an elderly gentleman. He had end-stage heart failure. He had been under the care of the community palliative care team. He had written an advanced care plan and said that he wanted to avoid admission to hospital. Unfortunately, he fell and had a fractured neck of femur, which is kind of one of the rare circumstances where people may say they don't want to come in, but they end up coming in often because they're difficult to manage in the community without being in hospital. He had it pinned, and then strangely, I'm not entirely sure why he went to a rehab hospital. I suspect he probably just wanted to go back home, but then he was transferred back to acute care after he'd been in a rehab hospital as he had a chest infection, and then he died quite quickly a couple of days later. And it basically sort of says essentially that his wife recognised he was dying. She thought, because he had got an advanced care plan that in place, that people would understand that he didn't want heroics. Actually, what he wanted was probably not to be in hospital. He didn't want distressing interventions or treatments. However, we still continue to focus on all of the things that actually he didn't really want. And so when he died, she wasn't here at the bedside. I don't know if you can actually read it, but essentially it says, because the doctors were so busy trying to save him, I was not contacted to come to say farewell. I was finally called. I left home immediately, but by the time I got there, he passed away. This is painful and unacceptable. The nurse on duty told me that she had held his hand when he passed away. I realised death is uncertain, but she had actually proactively rung the ward a couple of times that morning, and no one had answered the phone. She asked the nurse to ask the doctor to ring me as soon as he got in, she was afraid, so the relative was afraid that her husband's edema was so bad that he might be dying. So she had appreciated that, but we had focused on actively managing a situation that was probably very unlikely to be reversible, and not him spending time with his wife and acknowledging that he was dying. So how we care for patients essentially and even when they are dying and at the end of life, it really matters, because this will have clearly had long-lasting impact, and she wrote in to talk about it, and she's not an isolated case. So where to start? I want to try and make it relevant to you on the job. So you start with your on-call shift. You're asked to come down and clerk Roger. Yeah.
Sorry, I just have a question about that complaint that was made. So she says that she wrote on a piece of paper, no heroics, but if he doesn't have a respect form that actually outlines what...
So essentially he had an advanced care plan. So an advanced care plan is very similar to a respect form. It was a written document saying, I don't want medical intervention or treatment, I don't want to be in hospital. So it would have been, it was probably pre-respect use in hospital, so it would have been a very similar plan in place. Are they mean that? But I can go through advanced planning, I go through that a bit later. So basically, starting on the job, you're asked to come and see Roger. He's an 83, he's been brought in by ambulance. He's come from a nursing home where he's had a fall. He fell from getting up from a chair. He's been a bit lightheaded. He's had no chest pain, but he's short of breath. And he's got a productive cough. So I will go through a bit quicker because I'm conscious of time. You ask a few more questions. Basically, he's got a history of COPD, ischemic heart and hypertension. He's been on a number of medications, and he's recently starting having long-term oxygen therapy. He was mobile with a Zimmer frame, but his mobility has been declining over the past year. He was living independently about a year ago, but actually he's had multiple hospital admissions, and he's now in a nursing home, and he needs assistance with most activities of daily living. His daughter lives relatively nearby, and she's visited her dad regularly and has been quite concerned about how he's getting on. So is there anything in that history that flags up that this gentleman might be nearing sort of his last year or have a relatively poor prognosis?
I think his frailty score will be quite high. But also, isn't long-term oxygen at home something you do in the end stages of COPD for symptom control?
Yeah, so you can, it's basically when your COPD is quite severe, you can survive for some years with it, but it's definitely not a good prognostic factor. And the fact that actually was mobile, functionally declining, now needing a Zimmer frame, falling despite being at a nursing home, all to me sort of signals some alarm bells. So you send him for an X-ray and you do a bit more digging. Where would you go to if you had to do a bit more digging? Plexus, absolutely. Plexus is brilliant to get an idea of what the GPs have been doing, what interactions they've had anywhere else.
Evolve.
Yeah, so you can look through the previously scanned notes and Evolve. And when you look through those, you realise he's actually had 4 admissions over the past year. 3 have been for infective exacerbation of COPD and 1 for a fall. Every time he's been in hospital, he's needed more care. He has a DNA CPR form, but no advanced care planning discussions or respect form. So in terms of, has anyone heard of the gold standard framework? So there's something called the GSF. It was created by a GP called Kerry Thomas, and it's a tool that is often used in general practice or the community, but it has specific indicators for poor prognostic indicators for certain conditions, so sort of cancer, but also non-malignant conditions, so end-stage respiratory disease, end-stage heart failure. So in somebody that's not eating as much, losing weight, has had more than 3 admissions to hospital with COPD in the last year, they are all indicators that he's likely to be in the last year of his life. Okay. So if you're not sure about prognosis, that's probably quite a good resource. So you do his OBS, and he's got a BP of 138/90, temperature's 37.1. He is hypoxic, his SAT's 86 on room air, he's short of breath, wheezy, he's got crepitation in the right base, and he's got a pulse rate of 98. What would you do for him? Treatment-wise? He's got productive conservative cough. Antibiotics, yeah. Anything else? Yeah, nebulizers.
I'd probably look to see if there's a respiratory letter that outlines his saturation target. Because if he's already on home oxygen, it's not that low for an end-stage COPD patient, and he might not need any at all.
No, or you would aim for SATs of 88 to 92, I think, yeah, with him. So I'd probably put him on have it a target saturation range in his notes. So yeah, I agree. I think my plan was. Oh, wait a minute. I'll tell you my plan, but anyway. So looking at those obs and thinking about the picture, that's my next question before we think about what we actually started on, was is Roger dying? So at this stage I said he might possibly be dying, basically based on the fact that we don't have a crystal ball. Sometimes COPD patients come in, they look very unwell, we start some treatment and they do recover, but often not quite to the baseline that they had before, which seems to be the picture with him in the past. But there are some treatment options with him, and I agree absolutely. What I would do is start what you suggested. Antibiotics, steroids, some steroids if he's really wheezy, nebulizers and oxygen. I think what would be really helpful at this point would be to make sure he had a DNA CPR and a treatment escalation plan, but actually this doesn't happen. So you go off, and a few days later your bleep goes off and you're called back by the nursing team to see Roger. He has deteriorated, he's in distress, he's hypoxic and agitated. These are his observations. So he's a little bit more hypoxic, but he is on oxygen with USAT, so it is different to before. He's much more wheezy, he's confused, he's tachycardic, and he's hypotensive with a temperature. His news is 13, so you put out a MET call because he doesn't have any treatment escalation plan or anything else. So you're at the MET call and the team arrive. You're frantically trying to get bloods, he's not letting you do a blood gas, someone's trying to put some BiPAP on him to see if that will help. So NIV quite often happens in these circumstances. Even though people are confused and agitated, he's trying to pull it off. You get a cannula in, but as you do so, one of the nursing staff or the critical care outreach turns to you and says, is Roger dying? So if you had to vote for this time round, is Roger likely, or is he dying? I think he's highly likely to be dying. He's confused, so your ability to carry out or keep on any non-invasive ventilation like BiPAP will be very, very difficult. To keep BiPAP onto a confused, agitated patient is hard. He's not going to be a candidate for ITU or escalation of care. You've already got him on antibiotics, steroids, oxygen, nebulizers, so actually really thinking about it, what is your escalation plan beyond this if this isn't already working? So in my view, this is when I come and go, actually, look, we're not really winning, we need to think differently about what's happening with Roger. But in reality that doesn't always happen. Some people get, they continue to have non-invasive ventilation despite putting it off, and then it gets put on again and it gets put off again, and you go through this sequence, and that's kind of what we're trying to, as a palliative care, get people to step back and think about the bigger picture and say, actually, is this actually actively going to work or not? So these are random questions in case someone had extremely good palliative care knowledge, which I'm sure you all do, but the drugs don't work as a song by which rock band? It's more leveler questions. The answer is actually the Verve. So I think you can probably type in for this one. What would your next steps be? So I'm just going to see. So you're typing. It should come up. So you're typing. Okay, so if we go through and start, absolutely. So again, yeah, I absolutely think at this point, I think he's reaching the end of his life. So we're thinking about palliative care and how we manage him. So if we start by keeping him comfortable, someone's already kind of alluded to what medicines we might use. So what would you prescribe, and what indications would you use each medication for? I get you to talk through what you would prescribe for him and why, or what would the drug be for?
So protocol,
Yeah.
palliative care,
Yeah.
participators. And then pure morphine and pyridoxalam.
Yeah. So morphine. So what would morphine be for?
I guess really would help his breathing.
Yeah. Do you know what kind of the evidence base of morphine and breathlessness is for? Yeah. No. So basically, up to the equivalent of 30 milligrams of oral morphine in 24 hours has been shown to have benefit for relieving the sensation of breathlessness. So it won't take it away completely, but it might reduce it down. And the normal sort of dosage would be 2.5 to 5 milligrams. Subcut PRN, sort of 2 to 4 hourly. The way morphine works is normally with sort of say Oromorph, it works after about 20 to 30 minutes, got a peak effect around an hour, and it wears off after about 3 to 4 hours. So if someone is going to get benefit from morphine, and they're saying to you, oh, it works in the first minute or two and it lasts for half an hour, that's not the right sort of profile. This is where someone's got opioid responsive, either pain or it's helping breathlessness. They've shown that in breathlessness, if you start sort of 10 milligrams, so 5 BD and MST, that's often quite effective. If you go up to about 10 BD, about 70, if you do 5 BD, about 70% of people respond to that. If you do 10 BD, then about 92% of patients respond to the breathlessness. But you need to see how each individual tolerates morphine. Some people would prefer to start by giving them some Oromorph regularly and seeing how they can manage it. In his case, he's confused and agitated, and I suspect won't manage anything orally. But once you've established someone can tolerate it, you could start MST 5BD, or if somebody like him, you can give them some stats and then start a syringe driver. So that's a short breath or pain or discomfort. If his eGFR is less than 30, what do you give?
Oxygen.
Yeah, absolutely. And if it's really low, you can give something called alfentanil, so eGFR less than 10, but that's very potent, and a lot of the wards may not be familiar with it. Next drug, Benzodiazepine. So again, benzodiazepine. What's that for?
Agitation.
Yeah, so that's sort of agitation, distress. Again, 2.5 to 5. PRN, same sort of profile. If you're using it for seizures in a syringe driver, you would start with 20 to 30 milligrams. But for seizure management, you use 5 to 10. But for agitation or distress, you use 2.5 to 5. Anything else? Yeah. So hyoscine, butyl bromide. So if you take this orally, it's really poorly absorbed. There's only about 5% absorption, but subcut is well absorbed. And we normally do 20 milligrams subcut. PRN is about 6 hourly.
I've heard mixed things about hyoscine in that it doesn't really help the patient. More it helps the family, and sometimes can cause the secretions to be even thicker and more difficult to bring up anyway.
Yeah, so if someone had really, really thick secretions and they were struggling to expectorate them, you can try hyacinth to try and reduce the volumes, but there's a risk that they will plug off, and you need to talk to them about that. So if you're looking at symptom management of secretions, you're either looking at nebulizers, hypertonic saline, carbocystine to loosen it, or you're looking, or in his case, he wouldn't tolerate any of that. But so in his case, you may try some hyacinth, you might want to try a stat. In terms of if a patient has lots of secretions, there's the quickest thing to do to help secretions is to reposition somebody. Not suction them, but reposition them. If the hyacinth is going to work, normally you should start that early and see. Again, it's not brilliant evidence behind it. It can help or not. I would say try and get in there earlier. And yeah, if someone's really, really dry and looks, really dry, then I might just give stats. I might not put in their driver. So again, it is for secretions and it is for colic. But you can give a stat and see, and if they are very, very wet, I would reposition them. And do you know what else you would give?
Some antiemetic.
Yeah.
So cyclism or.
Yeah. And do you know what antiemetic you would choose? Does anyone know anything about antiemetics?
I know that there's many and they all work differently.
Yeah. They have loads of time, but tell me an antiemetic. So you've told me cyclisine. What does that work on? If I draw out
The brain?
GI tract, we know receptor trigger zone. So if you have cyclisine, where does it work? So basically you have input from when you are feeling sick, the cause of your sickness stimulates different receptors and they send signals to your vomiting centre, which is this, which is in your brain, and this is a blood-brain barrier. And then the vomiting centre sends out the stimulus and you get peristalsis and you start vomiting. So the reason for sickness will influence what you choose as an antiemetic. Okay? So if you give cyclisine, do you know what receptors it works on? Anyone? So it works on acetylcholine and histamine, which basically is your vestibular system. So what sort of things make you feel sick if you've got vestibular sickness?
Being on boats.
Yeah, travel sickness. So travel sickness, cerebral pontine angle tumours, any opioids can slightly affect your vestibular system as well. So some medication. So that's your motion sickness, inner ear tumour, labyrinthitis type cause of sickness. So if you did that, you gave them that would block the signal coming from there, and ideally you would feel much better and not feel sick. If you name another antiemetic.
Metaclopramide.
So what does that work on?
GI tract.
Yeah. How does it work on the GI tract?
Reduces peristalsis.
Yeah, so it works in two ways. It's prokinetic. What other receptors does it work on? Anyone know? Who shouldn't you give it to?
Bowel obstruction and ALS? No, Parkinson's.
Yeah, so complete bowel obstruction because it's prokinetic, and if you have a complete bowel obstruction, you don't want to stimulate bowel, get a total obstruction. If it's partial bowel obstruction, you may use it if they've got gas. So Parkinson's, what do Parkinson's patients not have? Dopamine. What does this block?
Dopaminergic
Yeah.
receptors.
Basically, so it blocks dopamine, so D2 receptors. trigger zone. Particularly things that work on this area are things like chemicals, so drugs, high urea, so renal failure. Those are the sorts of things that affect this part of the chemoreceptor trigger zone, which is in your brain. So the metoclopramide is good for those, or it's good if you think someone's got a massive liver squashing their stomach and you want to move things through. Another drug that's really similar to that, but we don't use anymore. No, domperidone, but you don't really have it anymore. We don't use it that much. Metoclopramide is much more flexible in terms of its, you can give it subcut IV orally. But on Danstron, what does that work on? Someone mentioned it, yeah. So 5-HT3 receptor antagonist. This is a really basic view because some of these drugs do others, so metoclopramide at high doses does 5-HT4, but this is a simplified view. So 5-HT receptor antagonist, do you know what sort of things, what sort of situations you use it in? Chemo, yeah. So chemo and radiotherapy tend to really affect the 5-HT receptors, 5-HT3 receptors. So when you give ondansetron, it's really good at blocking those signals on those 5-HT3 receptors, so it stops feeling sick. So that's why you give it for that. You sometimes might give it, you might see it in surgery when you've had bowel surgery or bowel stretch, because I think there's some 5-HT release when you have that done. We don't like it as a general antiemetic because it's got very specific uses and its side effect is severe constipation. So it makes people really constipated. So if actually you don't identify why they're being sick and you give it just as a kind of not sure, and then you make them really constipated, you're probably going to make them feel more sick. There's probably two others that we use. Haloperidol. Anyone know what that works on? You shouldn't give it to Parkinson's patients. Yeah, dopamine. So it's a really profound dopamine antagonist. So again, would work here particularly, and good for kind of chemical causes, high calcium renal failure. And there's one more that we use quite a lot that will be on that palliative care drop down. Levo, yeah. So levomethomazine is a really broad spectrum anti-sickness. It works on dopamine, acetylcholine. I suspect probably 5-HT or histamine, definitely one of them. Works on loads of receptors. It's an antipsychotic. It is really effective. It works on the blood-brain barrier. It covers loads of causes of sickness, which is why it's really effective. But because anything that crosses the blood-brain barrier can make you a bit sleepy, so cyclizine, levo, metoclopramide, that's why you get your Parkinson's problems, because it works here. But it's really good, but it can make people feel a bit sleepy and it can drop your blood pressure. So when we use it, we tend to try and think about cause of sickness, and if we haven't identified other antiemetics that aren't working, we tend to use it as a second line. So the other thing with anti-sickness is think about the route. If they're being sick, they won't absorb what you're giving them. And then, so you can give a subcut IV or potentially IM. And think about combinations. If you've got a patient who is on an anticholinergic, so amitriptyline, cyclizine, and you give them metoclopramide, why wouldn't you use that in combination? So what does metoclopramide partly do?
Blocks serotonin.
Blocks dopamine, but the other way it works was, you mentioned it before, it's a prokinetic. So it's prokinetic. Anticholinergic medicines, what do?
They slow down.
They slow everything down. They slow down, so they make you constipated, they make you feel a bit dry. So if you give a prokinetic and anticholinergic medicine together, theoretically it's counterproductive. So you wouldn't use them together. So if I wanted some dopamine antagonism with cyclizine, I would use haloperidol. So if I night out, and I made you eat a really massive meal, I can remember if you need it, and you ate loads of food and you felt really sick, what anti-sickness would you choose? Based on the fact it's a, yeah, so you would have metapropylate because you feel really full, so you've got your stomach feels really bloated, so you would take it and you would take some of it and you feel much better, so you go out and you drink loads of alcohol and you feel sick again. So what would that be? So what sort of substance is alcohol? It's a chemical. So that's affecting your chemoreceptor trigger
So
zone.
it still would work. That's a lot of mind.
It would, but you've decided that you've got access to all drugs. What would you? And say I would choose, yeah. The next day someone was saying it. Not, you want another dopamine antagonist, but one that's even better than metoclopramide. Haloperidol. Yeah. So, I mean, theoretically, you shouldn't take it because you've just taken metoclopramide and you might get
And also alcohol.
Parkinson's side effects. But this is just how to make you remember what to give in certain situations. So, ideally, you would choose a dopamine antagonist that was more potent, and you would have your haloperidol. So then you go out and you decide actually you feel really rotten, you're a bit tired of the haloperidol, so you go home and you take a taxi and you go down a winding road. So what cause of sickness would that be? Yeah, because it's your vestibular. So that's your winding motion sickness.
Oh, sorry.
Yeah, glycosine. And then there's one thing I haven't mentioned, but if someone has anticipatory nausea and vomiting, so you get back in a taxi the next morning because you've realised you've left your car in town and you smell alcohol and you feel sick again. Does anyone know what we give for kind of anticipatory sickness? That kind of, it's a core instinct from when we were primates a long time ago, and you saw someone eating something poisonous and they were vomiting, so it makes you feel sick because it's a protective mechanism to stop you eating whatever they've eaten. So we give benzodiazepine, so sometimes something like lorazepam. So generally, if I was writing up an antiemetic, I mean, you might write up cyclizine or haloperidol, and I think our protocol is probably more cyclizine, but I would think carefully. Yeah.
What tends to be most effective in morning sickness?
So I think that you're really limited because of being pregnant. So I would check which ones you can have. Do they give propylpyrazine? I can't think of Stental.
I saw a pregnant lady the other day, and she said that in her previous pregnancy she managed it with cyclizine and ondansetron, but
Yeah.
I don't know based on the mechanism.
Promethazine maybe, which I think is that's anti-vestibular. I suspect they can't have dopamine antagonists.
No, it's promethazine or cyclizine.
Yeah, I think you're really limited to what you can give pregnant people because of effects on kind of neonates. But yeah, so I would check, but I think your choice of drugs is far more limited. It's a bit like if you have Parkinson's, your choice of drugs is limited to cyclizine or ondansetron. Possibly levo, but you'd have to be a bit careful because it still has dopamine antagonism. So, yeah, so I think I would probably ask the obs and gynae people about that. But that's just, so basically those are the drugs we would write up, and the antiemetics don't just blanket prescribe because you think that someone always gives that antiemetic. Try and think about what the cause is and try and tailor your prescribing a bit. It's not an exact science, but I think it's a helpful way of trying to make sure the drugs that you use will work most effectively. So yeah, this is just kind of what we routinely suggest. So has he had any ACP discussions? Basically, this is advanced care planning. What you want to do at that stage is, he's not able to tell you because he's quite confused, but you want to try and find out, has he had any discussions, where would he want to be, actually is he physically well enough to be transferred anywhere, but if he isn't, what is important to him, who is it that he wants around, who does he want contacted, what are his spiritual beliefs. So there's somebody on the ward that we're seeing on respiratory who's having near episodes. Actually, she and her partner have been together for 34 years. She could die spontaneously from any of these events. She got married on Saturday. So, yeah, it was really, and then he's proposed twice, and he's never said yes before. But he got down on one knee when Tim and I were in there, and it was all really very sweet. Yeah. Yeah. So, what is advanced care planning? And you can organise weddings very specifically if someone is quite imminently dying. Well, or there's a risk. I don't know whether she is. Yeah, I think they probably did hers at the bedside. So there are specific circumstances. Yeah. So it's a process enabling individuals to plan their future care or their future wishes. It's not legally binding, but there are forms of advanced care plans that are. So, but the problem is we don't always discuss it. Despite this, what's the probability you will die?
What, us? Like,
yes, anyone in life.
100%.
Yeah. So basically, sorry, I'm quite pushing time to started late, but essentially the only guarantee in life when we are born, well, is that we will die, but we don't, and we discuss birth plans and all sorts of things, but we have a reluctance as a society often to discuss death and dying. This is commonly portrayed in the media. When we look at death and dying, it's quite sensational, it's quite extreme, and often the things that are reported aren't normal death and dying. So which of these causes the commonest number of deaths in the year?
definitely the left hand does
Yeah, so it is left-handed person using a right-handed product. It's about 1 in 300 million for a shark attack, even though some people are really scared of going in water and being eaten by a shark. Obviously your statistical chance gets higher depending on whether it's shark infested or not. Falling coconuts, about 150 people per year. Lightning is about 5 people per year. Men are 4 times more likely to be hit and killed than women.
What?
Why?
What?
I don't know why. Maybe they're out there. I don't know. Under trees, I don't know. Hello, sorry Nikki. But basically, more than 2,500 people who use a right-handed equipment but left-handed die per year. So and it's normally power tools. So it's basically saying that actually what you see in the media might well skew your thinking about death and dying.
Oh my god.
And it can very much be that we don't discuss it, so it's a bit like spiders. So you psychologically swerve situations that you're not comfortable with. So people who don't like spiders will psychologically swerve it. I'll move on to the next slide. Yeah. And that's because we don't have it often, we're not exposed to it, and we're not exposed to normal death and dying. But in the Victorian times, it was completely part of day-to-day life. When people died, they were in the funeral parlour in a temporary coffin waiting for the undertakers. Actually not being celebrated, your death not being celebrated was felt to be kind of socially you were, haven't succeeded. So that was a really big normal thing. Families would see it. So people talked about death and dying. And I think it's a particularly Western thing we don't do this. So if I show you these, what do you think they are? Yeah, so they're coffins. So say community in Ghana who basically spend more on their coffins than they do on their weddings, because death and dying is very much something they want to celebrate someone's life, and so they talk about it a lot more than say we do. So if you had to ask Roger before he was too unwell, because he's now too unwell, about death and dying, what would you ask him about? Sorry, it's the next speaker here.
Sorry?
There's the next speaker.
No, I was just coming to listen to that.
Okay.
It is hard past with an eye.
Yeah. Yeah. So it's absolutely, who do you want with you? Where do you want to be ideally? What do you not do or not want? I think if you ask most people if they want to be attached to several drips, dying with lots of machines around them and none of their family, versus comfortably dying with those interventions having been stopped because they're not working and spending time with the people that they want. I think in our society, generally, the people would choose the sort of situation without the interventions. That's not to say that's where everywhere in the world. So there's certainly countries where if you don't die on drips and all the interventions, it's seen that you haven't had everything done for you. And that can be difficult culturally when we look after patients from those backgrounds, when we're trying to explain what we want to achieve for patients here. But it's about who they want with them, what they want. Do they want music? Do they want family? Do they want pets? Do they want specific things? What's really important to them? Do they want to get married? Have they made a will? Because actually they haven't made a will. It's really complicated if they then die and there's specific things they need to sort out. So basically it's about doing it their way. So who has not released a cover version of this song? Everyone else. You see, weirdly it's Gary Barlow. He's still done lots of cover versions, but not this one. So we just said, I said some types of ACP are legally binding, some aren't. Do you know which of these is legally binding? There's only one correct answer. So the respective answer is an ADRT. So the correct answer, sorry. A respect or DNA CPR form is not legally binding. So there may be circumstances where someone has a DNA CPR form and you may choose to resuscitate them. It's very clear that it's an expression that is probably not in most circumstances the right thing to do. But for example, if you're in the hospice and somebody was started choking and they were in the having an anaesthetic and they react to the anaesthetic and you realise there's a very straightforward solution that you could reverse that, you may choose to reverse that. But if they have a respect or DNA CPR form, you should ideally follow those unless it's very different circumstance. Advanced statement of wishes is just, it's not legally binding, it's what they are expressing. Next of kin decision making is not legally binding, but they can appoint lasting power of attorney for health and welfare or finance, and a lasting power of attorney is legally binding. If they have an LPA and they lose capacity, you must seek the views of the LPA for health and welfare.
So the lasting power of attorney, is that, when you say that's legally binding, I understand that it means that we have to talk to that person.
Yeah.
But that doesn't mean that, like, if that person says no, you have to resuscitate them, that doesn't mean that that's legally binding.
No, because resuscitation is
It's
absolutely a
still a
clinical decision. But if they should treat them as essentially a proxy for the patient. If they are not representing the patient in a way that you think actually is that you are concerned about them representing in accordance with the patient wishes, then you would speak to the office of, you would ask the public guardian, you would seek kind of independent advice about that.
How does that kind of work out logistically when people are, say, end of life, if it kind of is long drawn out arguments and things? Because it must be tricky in palliative care.
Yeah, so if someone has an LPA, it's only when they lose capacity. Ideally you would already have a good idea of what your patient's wishes are because you would have talked to them, and actually if they lose capacity, you would theoretically you should ask them about every injection, every drug you give them, but you would outline the situation of the LPA. You can have loads of LPAs, it can be really complicated, it can be really difficult if the LPA isn't acting in accordance with their relative's wishes. So yeah, occasionally we have had to seek sort of higher authority, but yeah, it's not always easy to So do you have a question? Sure. Sorry, I'm conscious the next person will come. So essentially think about ACP when they initiate the conversation, when they're being diagnosed with a progressive life-limiting illness, whether it be malignant or not. When the condition changes, you might want to specifically put a point in time that you review them, or when you see them in clinic or things change. So just to ask, do you know what the Kalman gap is? I don't know if I'm nearly finished.
Oh, I don't send.
So it's the gap between the expectation of a situation and the reality. It was described by a philosopher. Basically, it's saying if you set someone's expectations unrealistically high and the reality is completely the opposite, there is a much higher risk of suffering going to happen because you aren't meeting their expectations and you've got expectations. So if you have a patient who's having second, third line chemo, their LFTs are completely gone off, they've got progressive liver mets, they're not going to be well enough for chemotherapy. It's much easier to say, well, not much easier, it's very difficult to say it, but it's much more honest to say something along the lines of, you know, this is tough, I'm really sorry, we can't change this, rather than to say, oh, actually, we might see you in, as I hear all the time, we might see you when you get a bit better in clinic in 4 weeks' time, and we'll review the decision from chemotherapy. That's really unlikely to happen in the majority of cases. You know, if you are dying and things are progressing and treatments aren't working, most of the time, particularly with cancer patients, we aren't going to be able to change those circumstances. And rather than phoning the Marsden again to seek second, third, fourth opinion, we have to be honest with patients so that we actually can work out, okay, we're not on a treatment trajectory, but we're on a pathway, well, we're on a pathway at all. We're in a situation where we need to work out what your priorities are in this situation. I cannot change what's happening, but I can try and facilitate what you want and where you want to be and what's important to you. So it's a different type of approach. And this is just about when you're having conversations. We are trying to do some sim teaching actually, looking at kind of end of life conversations, breaking bad news, difficult things, and we will be doing some pilots of that. But it's about just sort of getting them to paint a picture, thinking about what they understand is really helpful, sort of saying actually if you weren't very well at Easter, or if you weren't very well at, you were well in the summer but you're not well now, things are changing, how does that feel to you? And then making sure they understand and use language that they know or they use. Sorry.
People waiting for 2:30.
Yeah. Sorry. I'll just say basically, the Queen was a great example of normal death and dying. She died. She chose to die in Balmoral. She deteriorated. She appointed Camilla as the Queen's consort, so she kind of was a good example. And there are people in the media. So there is more social media, there is more exposure to the fact that people do die of things, that they have treatments, but actually people are talking about Balgrave, talked a lot about kind of, she died at home with her children supported by the hospice rather than in hospital. There's a lot of kind of legacy stuff. So I'd contact his daughter, I would talk about what she knows, explain what's happening, make sure the important things are sorted out. Make sure she's got car parking pass, so she's not paying £16 a day for parking. She knows where toilets, cafes and things like that are. And basically that's your checklist. You know, hydration, nutrition, actually it's about mouth care. Fluids we give occasionally, subcut, but not often. What his broader needs, spiritual needs, what his individual needs. And then after death, verify death, last exam, medical exam, we'll go through the paperwork. Bereavement office are there for support, so those sorts of things. Basically, if you want to learn, don't be afraid to ask questions, be curious, ask why we're doing things, speak to the Palliative Care team, speak to the CNSs. They are really experienced, really supportive, they know their stuff, and they're really good at communication as well. Sort of learn from others, whether it's done well or badly as well. And don't be afraid to call us for advice. I think that's just some things. I'm sorry we started late with all the IT.
Thanks so much.